Great. I think we're just about ready to start our second session, and I have the pleasure and the honor of introducing the esteemed faculty for this second session. My name is David Liu. I have the honor of introducing Dr. Dan Granberg, who many of you probably know through your either research circles or from a clinical realm. He is a consultant in the Department of Endocrine Oncology at Uppsala University. And just for those of you who may not be familiar with the European system, that does mean that he's a full staff attending at the university. He's dedicated virtually his entire career to carcinoid and neuroendocrine tumors, and specifically on bronchial carcinoids, and has spent at least the last 17 years publishing and actively researching this area in this field. He's currently involved in many research projects in the field of neuroendocrine tumors. And once again, I have the honor of introducing Dr. Granberg, and he'll be speaking specifically on lung carcinoids.
Thank you very much, David, and thank you for a nice introduction, and thanks to the organizing committee for inviting me to this city and this beautiful weather. So, lung carcinoids. This is a bronchoscopic view of a lung carcinoid in the right bronchus, pedunculated, small, red tumor. The definitions, according to WHO classification, which was based on a paper by William V. Travis in 1998, is that typical carcinoids have less than 2 mitosis per 10 high power fields and no necrosis, while atypical carcinoids have between 2 and 10 mitosis per 10 high power fields. They may contain necrosis in addition. The incidence of lung carcinoids has been increasing as of all the other neuroendocrine tumors which Professor Roberg told us about. All age groups are affected, even children, but the peak incidence is in middle ages. Women are slightly more affected than men. We don't know the etiology. There is no relation to smoking as far as known. The only known correlation is that patients with multiple endocrine neoplasia type 1 have an increased incidence of lung carcinoids. This is a typical lung carcinoid stained by hematoxylin and eosin, and you can see the regular pattern and the fibrosis tissue, the fibrous septa within the nests. Lung carcinoids, as all other tumors, stain positive for the neuroendocrine markers chromatin A and synaptophysin. This is a chromatin A stain of a strong positive stain of a typical lung carcinoid. They also stain positive for a variety of hormones such as serotonin, bombesin, gastrin, calcitonin, pancreatic polypeptide, and adrenocorticotropic hormones. And multiple hormone positivity is a common feature of these tumors. These tumors may secrete a variety of products such as adrenocorticotropic hormone or corticotropin-releasing factor, growth hormone-releasing hormone, serotonin, histamine, gastrin, PP, calcitonin, and of course the chromogranins A and B. We heard a little about the symptoms. About up to half of the patients are asymptomatic and detected incidentally on chest X-ray, for example, during investigation for hypertension or a preoperative chest X-ray scan. Other presenting symptoms include cough, hemoptysis, dyspnea, wheezing, recurrent pneumonias, chest pain, and endocrine symptoms. Endocrine symptoms are rare. Only a few percentage of lung carcinoid patients present with these symptoms. And they encompass Cushing syndrome, the carcinoid syndrome, the atypical carcinoid syndrome due to production of histamine, and acromegaly. Metastases occur in 5 to 20% of patients with typical carcinoids and in up to 70% of patients with atypical carcinoids. The most frequent localization of metastases are the regional lymph nodes, but also distant metastases to the liver, bones, brain, subcutaneous tissue, and mammary gland, may occur. The diagnosis is made by chest X-ray. A little bit more than 50% of the tumors are seen on chest X-ray. However, we always recommend that a CT scan or an MRI scan should be performed for localization of a large lymph node in the thorax and for further characterization and delineation of the tumor. Central tumors may be accessible by bronchoscopy, and they may be biopsied safely. There has been a debate whether these tumors can be biopsied because of the bleeding risk, but the current opinion is that you can perform a biopsy. We recommend that the preoperative octreoscan scan should be performed in all patients in order to find out which of these tumors are octreoscan positive and to see if octreoscan scan can be used in the follow-up of these patients. Roughly 2/3 of the patients are positive on octreoscan. PET with 5-deoxytryptophan, which can only be performed in Uppsala, is recommended in very selected cases. Transthoracic biopsy is usually not performed for several reasons. There is a risk of misdiagnosis, confusion between atypical lung carcinoid and small cell lung cancer, although it has been shown that Ki67 may be used to discriminate between these diagnoses. The biochemistry, plasma chromoglobin A, I think, should be measured in all patients. However, it's usually normal in patients with localized disease. An elevated chromoglobin A may be an indicator of disseminated disease and distant metastasis, but it should nevertheless be done. Urinary FABHA and urinary cortisol should only be performed if the patient has symptoms of a carcinoid syndrome or a Cushing syndrome. The yield is otherwise too low. Here is an octreoscan scan of a lung carcinoid, clearly visible there and there. And here's the CT scan of the same tumor. Oh, sorry. There. This is a PET with 5-HTP. You can clearly see the tumor here, there. It was only detected by this method, actually. I'll show it on this slide, too. The treatment of lung carcinoids consists of surgery, radiotherapy, chemotherapy, biotherapy, liver embolization, and symptomatic treatment. And I'll say a few words of some of these. I would have had 3 more slides here, but due to time I had permitted them, namely 3 slides equivalent to this, because the treatment is surgery, 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 and surgery, not only surgery. This is the only curative possibility for these patients. And I have listed some of the methods: sleeve resection, segmental or wedge resection, lobectomy, bilobectomy, and pneumonectomy. And the principle should be to resect the tumor radically and to remove all affected lymph nodes and to spare as much healthy lung parenchyma as possible. It's extremely important that you perform a thorough lymph node dissection and that you use frozen sections to aid in the determination of metastatic lymph nodes. Because if you don't remove all the lymph nodes, I will tell you about the case report in my next session tomorrow, how it can go. But if you don't remove them, the patient is not cured. And you want to cure these patients. Pathology. You should perform, of course, cytokeratin to see that the tumor is epithelial, chromoglobin A, and synaptophysin to settle the diagnosis of an endocrine tumor. Serotonin is valuable in the discrimination between foregut and midgut carcinoids, of course, mainly if you perform histology of a metastatic tumor suspected to be a lung carcinoid. P67 always is important, as we have heard already. CD44, which is an adhesion molecule, has been shown by our group to be a prognostic marker in these tumors, and I think that it should be part of the routine immunohistochemical procedure for these patients. The radiotherapy, conventional radiotherapy, is mainly used against bone or brain metastasis, but could be performed against the primary tumor area if surgery is not possible, if the resection is incomplete, if the resection margins are affected by tumor, and in patients with atypical carcinoids with lymph node metastasis. I have to say a few words about laser therapy. Bronchoscopic aided laser therapy. It's only recommended in patients who are not amenable to surgery because of their general condition to try to open up the bronchus. I've seen a patient once with a lung carcinoid where surgery was refused because of the extent of the tumor. She received laser therapy, and when we planned her for radiotherapy instead of surgery, it showed up that the tumor had been delineated and it was possible to resect. This patient actually had, in addition to her lung carcinoid, a lymph node metastasis and also an adenocarcinoma that was resected incidentally. She was treated with a lobectomy, and she's yet several years after free of recurrence. Targeted irradiation therapy with 177 lutetium, octreotide, or maybe 990 octreotide, or indium in selected cases, all in patients with metastatic disease and high uptake on somatostatin receptor scintigraphy. The effects of biotherapy, I will show you soon. It consists of alpha interferon, 3 to 5 million units, 3 to 5 times a week, or PEG interferon alpha, 50 to 100, or even 150 micrograms once weekly. You should adjust the dose according to tolerance and leukocyte count. Octreotide, sandostatin LAR, 20 to 30 milligrams, 3 to 4 times every 3 or 4 weeks, or lanreotide autogel, or somatolin autogel, 90 to 120 milligrams every 4 weeks, subcutaneously. Here are some results of biotherapy. The first is our report where 15% of the patients who received alpha interferon showed stable disease and the remaining progressive disease. And octreotide or lanreotide led to progressive disease in all of the 4 patients treated with this. We have another report from an Italian group recently published where all patients with metastatic disease or recurrent metastatic disease received sandostatin LAR or lanreotide autogel as first-line treatment, and you can see that they achieved a higher frequency of stable disease, about 2/3 altogether, and 90% in typical carcinoids and 1/4 in atypical carcinoids. The chemotherapy, well, temozolomide plus capecitabine plus Avastin, streptozotocin plus 5-FU or doxorubicin, cis or carboplatin plus etoposide, taxane plus doxorubicin, oxaliplatin plus capecitabine, 5-FU dacarbazine, epirubicin, cyclophosphamide, doxorubicin, and vinclozine or cisplatin, etoposide plus paclitaxel are some of the combinations used. And I will share with you a few of the studies. This is from Sara Ekeblad and co-workers from our group with temozolomide as monotherapy, and you can see that roughly 1/3 of the patients showed partial response, 1/3 showed stable disease, and 1/3 progressive disease. And as comparison, I've included the figures for thymic carcinoids, where 70% was stable, which is also very impressive results. This is from our own report from 2001. 25% of the patients responded to cisplatin and etoposide, and another 12% was stable. We had a few patients with stable disease on doxorubicin plus paclitaxel, doxorubicin on streptozotocin. But the results on streptozotocin plus 5-FU were not that good. This is another study from Dori Wirth and co-workers in 2004. 18 patients, 8 typical and 10 atypical carcinoids. And the results on chemo and chemoradiotherapy was that 2 patients responded to chemoradiotherapy and 2 patients responded to chemotherapy alone, mostly with platinum-based combinations. This is a poster presented at the International Lung Cancer Congress in Seoul last year from a French group. I don't think it has been published as a paper yet, where 34 patients with atypical metastatic carcinoids treated with first-line chemo, and they found objective responses in 1/3 of the patients treated with streptozotocin and 5-FU, and stable disease in another third. And about 20% responded to cisplatin and etoposide. The total response rate was about 32%, which is 1/3. And second-line chemotherapy also resulted in a few responses, and about half of the patients showed stable disease. This is the study by the Dosso and co-workers, where all patients, 28, received long-acting somatostatin analog as first-line treatment. 10 of them progressed, and the second-line chemotherapy received either oxaliplatin plus capecitabine or 5-FU dicarbazine plus epirubicin. And you can see the response rates here. 3 out of 10 showed partial response and 5 stable disease. Neurotherapies encompass tyrosine kinase inhibitors such as imatinib, gefitinib, belotinib, sorafenib, sunitinib, and datinib, angiogenesis inhibitors such as Avastin, HDAC inhibitors as Verinostat, and RAD001. Here are the results. I will say a few words about lutetium treatment also. You require a grade 3 to 4 uptake on octreoscan, which means high uptake. This is the Krenning scale. It should be higher than normal liver uptake. And the bone marrow and liver function should not be too much comprised. We normally give 4 treatments with 2-month interval, and the maximum dose is 7.4 gigabecquerel per treatment. Here are the results from the Dutch group. 9 patients, 5 partial responses, 1 minor response, and 2 stable disease. And our own results, 2 patients, we have treated 6 patients, but only 2 are so far evaluable, and they all showed stable disease and progressed after 15 and 10 months respectively. The median time to progression in the Dutch group was 31 months, but they have far longer follow-up than we have. And symptomatic treatment, Cushing syndrome, metyrapone, ketoconazole, octreotide, and the carcinoid syndrome, octreotide, subcutaneous, intravenous, histamine 1 and 2 receptor blockers, steroids, and alpha-interferon, not to be forgotten. Some patients with the carcinoid syndrome or the atypical carcinoids may require alpha-interferon. How do you then treat these patients? Patients with low proliferative rate, consider biotherapy with alpha-interferon or somatostatin analogs, or temozolomide, streptozotocin plus 5-FU, and lutetium. Patients with intermediate proliferative rate, chemotherapy with temozolomide or streptozotocin plus doxorubicin, lutetium. And high proliferative tumors, patients should receive platinum-based chemotherapy as first line, maybe temozolomide, capecitabine, and Avastin, or taxanes. And experimental drugs encompass the RAS-001 and tyrosine kinase or angiogenesis inhibitors. The prognosis is usually good. The 5-year survival of about 90%, and typical carcinoids nearly 100%. Atypical carcinoids have a lower survival rate. And 10-year survival is also good. Many of these patients die from other non-carcinoid related diseases. Prognostically unfavorable features include atypical carcinoid, lymph node metastasis at diagnosis, and a high MIB1 or Ki67 index. And prognostically favorable, positive CD44 staining and positive nuclear N23 staining. And here you can see a positive CD44 staining, clearly membranous, strongly positive. What do I recommend? Analyze plasma chromoglobin A preoperatively, perform a preoperative or trioscan. Again, radical surgery, primary tumor, lymph node dissection, frozen section, stain for Ki67 and CD44. Long-term follow-up, at least 10 years. Remember that these patients may recur late. We have seen patients between 25 and 30 years, and I've also read reports of patients recurring 30 years after primary surgery. Increased attention to patients with high MIB1 index and lymph node metastasis and negative CD44 staining. Typical carcinoid. You can't hear this too much. Radical surgery, long-term follow-up. Atypical carcinoid, radical surgery, radical surgery, radical surgery. Consider radiotherapy and also close follow-up. There is so far no reports of the benefits of adjuvant chemotherapy to patients with lung carcinoids. And I want to thank the following person, and I want to thank you for your invitation and for your attention.
Thank you very much, Dr. Granberg. In the interest of time and also in the interest of the other speakers, we're going to refrain from a question and answer.